This is our presentation on Ankylosing Spondylitis by Kristen Muldowney and Morgan Bridges. This is a roadmap of where we're headed and what we'll talk about in our presentation. In Greek, ankylos means stiffening of a joint and spondylo means vertebrae, so putting it together, it's the stiffening of the vertebrae. Ankylosing spondylitis is a chronic rheumatoid disorder that belongs to a group of disorders termed seronegative spondyloarthropathies. This is a group of similar diseases that usually cause inflammation of the joints and the spine. They're termed seronegative because the patient will test negative for the autoimmune rheumatoid factor. In most severe cases, chronic inflammation leads to new bone formation on the spine, and the spine becomes fused in a fixed and in a forward flexed posture.
Some of the risk factors associated with AS are testing positive for the HLA-B27 marker. There's also a strong genetic component with family history of AS. There's a 5 to 6-fold increase in having ankylosing spondylitis if a first-degree relative has the disorder. There's also frequent gastrointestinal infections is another risk factor. A lot of the journal articles published recently are saying that there's a strong correlation between GI infections and the development of AS, and being a male and Caucasian are two other risk factors. The prevalence of ankylosing spondylitis is that it affects about 0.1 to 1.4% of the population, which is about 1 to 3 people for every 1,000 people. It's most common in Caucasians, and research has determined that ankylosing spondylitis to have an etiology of 4 to 5% of the population with back pain. There's a 3-to-1 ratio for males to females, and the median age onset is around 23. It's highly associated with the HLA-B27 gene, and 90% of the patients with AS have been found to have this gene. A person with this gene has about 5 to 6% chance of actually developing the disorder. There's currently no gold standard for the diagnosing of AS. A diagnosis of ankylosing spondylitis is made primarily based on the patient's symptoms, clinical exam findings, and imaging. However, HLA-B27 gene is not used to make a diagnosis of ankylosing spondylitis, although there's a high correlation between patients with this gene and those that develop the disorder. Typically, plain films of the SI joint are done first if there's any suspect of AS, because sacroiliitis is a cardinal feature of AS. However, using x-rays to detect AS involvement can be problematic because it takes about 7 to 10 years for the disease progression to show changes in the SI joint, which are serious enough to show up in conventional x-rays. Sometimes an MRI can be done, but not as much research has been focused on MRI imaging. Usually the patient has a history of inflammatory low back pain, and they experience decreased range of motion in a lot of their activities of daily living. This is just a chart that shows some of the clinical criteria and the radiologic criteria that is used to diagnose AS. There's a grading scale that says the probability of having AS is high if there's 3 clinical criteria present, or if the radiologic criterion is present without any signs or symptoms satisfying the clinical criteria. And we just thought this was a nice chart that could easily be referred back to while we're out in clinic.
According to an article that's cited in our textbook, if you ask these 5 questions to a patient and they have a yes answer to at least 4 of them, there's a very high chance that they have ankylosing spondylitis. These questions are: do you have morning stiffness? Do you have any improvement in your discomfort when you exercise? Did the onset of your back pain begin before the age of 40? Did the problem begin slowly? And has the pain persisted for at least 3 months?
This is some subjective signs and symptoms that you may hear your patient complain of while you're taking the history. Your patient may complain of constant, dull, and diffuse pain and stiffness in the low back, buttock area, and the hips, which has lasted longer than 3 months. Ankylosing spondylitis is a systemic disease, so this means that symptoms may not be limited to just the spinal joints, so it's important to ask about all the peripheral joints as well. Pain usually starts around the SI joint, and the pain and stiffness is worse during the night, but sometimes it'll improve with warm shower or light exercise. Patients may also complain of a hard time breathing due to the fusion of the ribs to the spine, and this limits a person's ability to expand his or her chest while they're taking a deep breath. They also may experience pain in the ligaments and tendons because of the systemic process, and they may have had a recent fever, fatigue, or loss of appetite, as well as eye inflammation consisting of redness and pain. This is just a picture that we added to help give a visualization of the process of ankylosing spondylitis. As you can see, a normal spine on the left has a nice S curve. On the right, the deformation shows a loss of the normal curvature due to the fusion of the spinal vertebrae. According to one study that was conducted by Gran, he looked at the signs and symptoms of subjects who were diagnosed with AS and those persons with back pain who were not suffering from AS, and compared the subjective symptoms that they were given during their subjective history. So some of the symptoms that differentiated best between subjects with AS and those without ankylosing spondylitis were that people with AS perceived back pain, which awakened them at night and usually made them get up out of their bed. Their pain was not relieved by lying down, but it improved with exercise. They had pain for at least 3 months, and their morning stiffness lasted for more than a half hour. Reduced lateral mobility of the lumbar spine, and total spinal extension of 20 degrees or less, and spinal flexion of 40 degrees or less. We also found that these criteria were very similar to those listed in the chart above, which is another reason why we added this study.
Some common clinical findings include a flat lumbar spine, gross limitation of side bending in both directions, bilateral and symmetric mobility loss, a loss of spinal elongation and flexion. It's common that these patients have a history of costochondritis, so when you do rib springing, you may feel a hard infield. There may be a decreased glide of the costotransverse joints or a decreased distraction of the SC joints and a capsular pattern of the lumbar spine. This is another picture that really shows the bamboo spine where the bones have fused due to inflammation of the joints over time. According to our textbook, a daily exercise program is very important for these patients in order for them to maintain their functional spinal outcomes, and the goal of this exercise program should be to maintain the mobility of their spine for as long as possible so that they do not stiffen up in an abnormal posture. These daily exercises should include positioning, spinal extension, breathing, exercises for the peripheral joints, and lying prone for 5 minutes several times each day. Studies cited by the NIH and the subset, the Institute of Arthritis and Musculoskeletal and Skin Diseases, determined that the patients that had the greatest functional limitations were the patients that had had the disease for at least 20 years, had physically demanding jobs, had other health problems, or smoked. Patients with higher education levels or with a family history of AS tended to have less functional limitations. The likelihood of having severe joint damage increases as the age of disease onset increases. Current smokers are 4 times as likely to have severe damage as a result of their disease than non-smokers are, and the presence of the genetic marker DRB1*0801 has been studied to possibly protect against severe spinal damage.
Finally, these are some of the more common outcome measures that are used with ankylosing spondylitis. We wanted to list them out for you in case you came across them in your clinical setting. However, the last one, the Oswestry Low Back Pain Disability Questionnaire and Oswestry Disability Index, is one of the more common ones that are seen in outpatient clinics. This outcome measure asks about pain intensity and pain with personal care, lifting, walking, sitting, standing, sleeping, sex life, social history, and traveling. So basically a lot of the activities of daily living that your patient will have to deal with. So we wanted to add that and make sure everyone had a reference for that. These are just a copy of all of our references, and we hope that you all enjoyed our presentation on ankylosing spondylitis.